Good day, folks. Alfie Vente here once again of Vente Pain Relief Clinic and VPRC.ca. So, this is a continuation of our soft tissue case study, Big Toe Pain Part 2. This is the answers and discussion. So, hopefully, over the last week or so, the previous week, you had a chance to read or watch the video for Part 1 for this big toe pain. This is one case where there's a lot of fascial involvement. So if you are a therapist, massage therapist, a chiropractor, physical therapist that deals a lot with fascia, soft tissue muscles, this might be something that you might be very interested in. So as I mentioned before in previous videos, these are case studies that are either a combination of different treatments that I've done over the past number of years, or it could be a singular. But most of the time, it's actually a combination of different ones, and I put them together as one case. So we're going to review the case study. Your patient client is an avid runner. By all accounts, they are in good health. Every once in a while, he notices pain in his left big toe. The pain gets to a point where he is finding that he either has to stop his run or at the very least cut down his mileage. So I'm very sure a number of you guys have had to treat people that have had this type of issue. It's very rare. It is very rare. Generally for runners, I find that there's a lot of hip issues, knee issues, hip flexors, lower back. Not so much in the big toe, but every once in a while I do get cases like this. Typically, he manages his symptoms well with a combination of treatments, massage and physiotherapy, or physical therapy, as you would say in the United States. About 6 months ago, he also sprained his left ankle. This was his first sprain. Initially, he felt that the healing went well and that he was able to eventually get back to his regular fitness activities. So, from the sprain, he basically, felt better after a number of weeks. And he felt like he was almost back to normal. So fast forward to the current time, and he feels that the ankle seems to feel tighter and has become less mobile. So when he moves it around, it doesn't feel as good as the opposite side. He also stated that there's still some swelling in and around the ankle. He wonders why there is still some leftover swelling because months have passed since the injury. He has seen his doctor and other specialists and has had scans done along with other Western medical tests, and all are negative. Generally with my case studies, you're going to find that I repeat this over and over again. Like they've had multiple tests, they've gone to different therapists, and everything seems to be checking out right, or they've had therapies done and it doesn't seem to be getting any better. So that's generally the theme of the case studies we have here. At the moment, the two key symptoms that he is noticing is the big toe pain along with the ankle swelling with seemingly decreased mobility. It also seems that the big toe pain has become more frequent with increased intensity and generally becomes more symptomatic during a run. So now let's take a look at the key observations. But before I go into the key observations, if you like our content, please like, share, and subscribe. Pass this on to those that you feel this might be helpful for. If you're on YouTube, please hit that notification bell. Also, if you are an instructor, I do invite you to pass this on to your students if you feel this is something that will be helpful for them. So now let's get on to the key observations. The ankle looks swollen, and on palpation there's noticeable fluid located around the left sinus tarsi to the dorsal aspect of the foot and just slightly superior to the ankle joint. So the top of the foot to just right above the actual ankle joint. On palpation, there are severe restrictions of the fascia. This is very, very important. And when I mean severe, it is so restricted that it feels like the connective tissue is wrapped tightly around the lower leg structures. So if you've ever worked on someone's back, someone's calf, someone's quadricep, whatever it is, and their fascia is restricted, you know what I mean. Like it's very hard to pull off. Like it just feels like it's glued on to the tissues underneath. The wrapped tightly around the lower leg structures. The restrictions extend inferior to the knee. So there's more restrictions from like just below the knee to the dorsal aspect of the foot. Upon testing, the length of the left plantar flexors, so this is general testing of the left plantar flexors. You observe that the left side is relatively more shortened than the right side. There's significant resistance on passive dorsiflexion. So when you do the dorsiflexion passively, you notice that there isn't much give relative to the opposite side, the more normal side. More on the observations. Testing both active free and passive range of motion of the left big toe, you notice that extension is limited. So you'll notice, pretend this is my big toe, that it doesn't move too well. Now, if you've ever assessed a big toe and you've noticed this, it feels very, very tight, very, very restricted. And in fact, at times a person might say, well, that's a little painful. Big toe slightly looks more flexed. So when you look at it upon observation, you notice that relative to the opposite side, it seems to be in more flexed posture. On the medial and plantar aspect of distal phalange of the big toe and on the metatarsal head, there is a noticeable callus. So this is very, very important. For myself, now I'm not sure about you guys, but calluses give me a big clue in terms of what could be happening mechanically with the person. In fact, the fascia, particularly on the foot, can lead me to work into the foot, into those calluses to release the fascia. You'll notice, here's a little tip. You'll notice that if you work on the callus long enough, the fascia releases. So that's something to sort of be aware of. There is some tenderness locally of the big toe, generally very mild. Palpation of the anterolateral aspect of the muscles of the lower leg, you notice increased tightness relative to the opposite side, and that a certain pinpoint section seems to reproduce the pain into the big toe. So when you're kind of poking around the sections of the anterolateral lower leg, you notice that at certain points there is some pain, and it reproduces pain into the big toe. All other Western tests are negative. So these were the critical thinking questions that I'd asked from the last week, a week and a half or so. So if you had the opportunity to write these questions down and potentially answer them, we're going to answer these now. What do you think is causing the pain in the big toe? What is your theory in regards to why the swelling has become chronic and that it has stayed static in the location? So in other words, it really doesn't look like it's moved. It's not like it was previously where you had the initial sprain and it swelled up like a balloon. This is more kind of like there's swelling and it's very noticeable, but it's not like a balloon. List 3 objectives in your treatment plan and the reasons for why you have chosen these objectives. And finally, what is your understanding of the pathophysiology of the pain of the big toe and the chronic swelling? So in other words, what were the mechanics, what were the stages to get to this point at the current moment? Let us answer number 1. Question number 1, what do you think is causing the pain in the big toe? So if you read and if you listen to the key observations, the direct cause of the big toe pain is a trigger point in the tibialis anterior muscle. This is a pretty fascinating one because I've seen this multiple times with people where I press into the tibialis anterior and it reproduces the pain in the big toe. Once the trigger point is released, the big toe feels better. A big clue that I mentioned is the pain pattern, and when the anterolateral lower leg is palpated, there is a pinpoint location that refers to the big toe. So the pinpoint location is very important. You press into the area, it's a potential trigger point causing the big toe pain. So here's the illustration here. Many of you guys probably have this framed up in your treatment room. It's the trigger point chart by Dr. Smulders, the chiropractor, illustrated by Tim Merton and Christopher McDonald. So the arrow is pointing to the trigger point of the tibialis anterior. You'll notice that it refers into the big toe. Question number 2. What is your theory in regards to why the swelling has become chronic and that it has stayed static in the location? So this is a very important one. This is one that I think is very major in regards to the overall treatment in terms of impact. So the chronic swelling is due to the amount of fascial restrictions in the ankle and lower leg. Relative to the unaffected side, there's substantially more fascial restrictions on the affected side. The restrictions prevent and or slow down the movement of fluid in an area. So think about it this way: when it's tightly bound, when the fascia is really bound, it can prevent movement of the swelling. So it's like being squished, kind of like the way I described it is like kind of like pressing your foot down on a hose. So this is very important to note. Release the fascia first before drainage. So we're going to talk a bit more about that, about releasing the fascia before the drainage. When swelling isn't cleared, it can cause more scar tissue to build and, of course, increase the pain, or maybe cause the pain to become more and more chronic. Okay, that's from the previous one. So question number 3, list 3 objectives in your treatment plan and the reasons for why you have chosen these objectives. Mind you, for this type of treatment, there's probably going to be more than 3 objectives, but these are the 3 major ones that you would want to look at in regards to working with this type of patient client. Number 1, release the fascia aggressively. Now, I'm not talking about going in there and just doing light techniques to release the fascia. It might work, but I got a feeling for the most part what I've seen is that it doesn't seem to help as much as trying to literally pull the tissues apart to get the fascia to release. And of course, that's not going to be the most comfortable type of treatment. As many of you guys know who treat the fascia, it can be fairly uncomfortable and fairly painful. Generally, what I found is that with athletes, like this one here, this runner, they tend to be able to handle this style of treatment. So after releasing the fascia, you decrease the swelling. And then the third objective is stretch out tibialis anterior and decrease the trigger point activity. Now, there's obviously multiple ones underneath that. There's potentially stretching out the plantar flexors to decrease the amount of tension in there. There's, mobilizing the big toe also. And, of course, later on, you might want to look at the pelvis, maybe the knee, and see if there's anything there that could be contributing to this person's issue. Question number 4. What is your understanding of the pathophysiology of the pain of the big toe and the chronic swelling? So basically what I'm asking for is what were the stages to get to this point, to this current point of more pain than what was expected in terms of the person's healing. So patient client had this issue even before the sprain. So they already had this issue where every once in a while, as mentioned before in the case, they'd get treatment for it, massage, and some sort of physical therapy, and it seems to manage it well. From the assessment, it seems that the patient client has very tight plantar flexors. Now, we're not just talking about soleus, we're not talking about gastrocs, we're talking about in general, the plantar flexors are very tight, which works as general antagonists to the dorsiflexors, specifically tibialis anterior. The tibialis anterior has had to work against increased resistance from the tight plantar flexors, increasing its workload, hence the trigger point. So remember, with tibialis anterior, it is a dorsiflexor, so it works the opposite of the plantar flexors. The plantar flexors are tight. Just imagine the person running. There's a bit more resistance trying to basically pull that foot up. The tibialis anterior is working a lot harder. In fact, most of the other dorsiflexors are probably working as hard too. It also seems that the flexor hallucis longus muscle on the affected side has become very tight from overuse. The actions of this muscle include plantar flexion and flexion of the small joints of the big toe. A big clue that has become overused is the area of callus formation in the big toe. So remember, I was mentioning about the callus and how, for me as a clinician, and you might want to try this out, you're going to notice that there's a lot of fascial restrictions. You release the callus, you tend to release the fascia with it. So it's a very big clue. The flexor hallucis longus, FHL, is an antagonist to the extensor hallucis longus. The extreme tightness of the FHL causes the EHL to overwork due to extra resistance. This compounds the pain in the big toe. So the extensor hallucis longus, it extends the big toe. Flexor hallucis longus is a plantar flexor and it flexes the toe. So just kind of similar to the tibialis anterior and the plantar flexors, such as the gastroc and soleus, they're working against that resistance of the tightness of those opposite side muscles and therefore working a lot harder. The patient client had the sprain, potentially causing protective spasming and swelling in the area. Although most of the swelling has gone down, the remaining swelling has stayed due to the tightening of the fascia. As I mentioned before, at times the fascia can become very tight and it will either stop the flow of the fluid, like moving out of an area, or it'll slow it down. The fascia has, in a sense, caused a number of issues, a number of ongoing issues. So number one, the tight connective tissue potentially has irritated pain-sensitive structures in the area. So it's very stuck. The pain-sensitive structures, nerves, muscles, bone. The tight fascia potentially has decreased the mobility of the ankle, thus compounding the work of the tibialis anterior and extensor hallucis longus. So if you've worked on a very tight fascia around the ankle, you will understand what I mean. When it's really, really stuck, you'll find that when you move the ankle around, there isn't much give. And this is, of course, relative to the opposite side. You'll notice a big difference in the way that the unaffected side is relative to the affected side in terms of motion of the ankle. So as a continuation of number 8, the tightness has potentially caused swelling to remain static, also adding on to the disturbance in the area. To relieve the chronic symptoms, one must focus on the fascia first before draining. So from a step-by-step kind of thing, you want to look at the fascia before, then the swelling before the muscles, and then the muscles last. So fascia before everything else. The swelling, you drain the area out and then work on the muscles last. So it may seem counterintuitive, but if the fascia is the thing that's restricting and causing a lot of the chronic issues, you want to get at it first. You'll find that when you release the fascia, the muscles also follow with it. So I know generally, like in rehab, we talk about myofascial, they're kind of one and the same. But for myself, I actually split it in different percentages. So for example, I might deal with somebody that has more fascial restrictions, maybe 70% of his fascia, 30% of its muscle. It could be the other way around. So I work with the tissues based on that kind of thinking. So there you go. That's question number 4. Now I want to know, what is your theory as to how you came about to your conclusion? I'm very curious to hear your answers. Please share your thought process below. It's great for conversational purposes and to understand what people are thinking in regards to this type of case. Thank you for watching once again, and remember, we have cases coming up, so pay attention to YouTube and LinkedIn. You will be seeing them in the future, in the near future. Please visit our social media. And also, please like, share, subscribe, and pass this on to those that you feel this might be helpful for. Again, thank you in advance. And also hit that notification bell if you are on YouTube. My name again is Alfie Vente of Vente Pain Relief Clinic. I hope you enjoyed this case study. For me, this is great to sort of pass on what I've learned over the years, and hopefully, you get some value out of like what I'm trying to show here in terms of like the videos that we have for the case studies. Again, my name is Alfie Vente. Have yourself a great day, and we'll see you in the next video. Take care.